Technology. She is the William J. and Charles H. Mayo Endowed Professor. She's past president of the American College of Rheumatology and currently serves as Dean of Mayo Medical School. She developed the highly successful clinical research training and career development programs at Mayo Clinic and served as co-PI and founding director of the education of the NIH-funded Center for Clinical and Translational Science Activities. In 2011, Dr. Gabriel was appointed by the U.S. Government Accountability Office in the Methodology Committee of the Patient-Centered Outcomes Research Institute, which will be a very important part of her talk. She's part of the this was part of the Affordable Care Act and became its first chair. Dr. Gabriel is PI of a long-standing NIH-funded research program in heart disease and rheumatoid arthritis. It is our privilege to have Dr. Gabriel, and thank you so much for being with us.
Thank you very much. It's really my pleasure to be here and to be part of these activities both yesterday and today. And I think it's wonderful how yesterday was really a celebration of history, of our history together, the history of your master's program. But today, we're really talking about how we can create this history together, what that next chapter will look like. So I'm really very excited to be here and to be a part of it. If my slides would come up, that would be really cool. They were up a minute ago. Perfect. Thank you. Thank you very much. Okay. So one of the things that, the picture's distracting me. I'm sorry. I'd just like to start with some comments that really resonate, I think, with our last speaker. And that is with respect to disparities and the whole notion of linking disparities to clinical and translational research. I'll sort of start with the premise that we haven't made as much progress as we would have hoped to have made by this time, if 10 or 15 or 20 years ago. And there has been a lot of work done in the area of health disparities. So despite these attempted interventions, and there's been a lot of people and a lot of institutions and organizations around our country working on health disparities, but the inequalities in health status in our country are large, persistent, and in many cases increasing. These systematic avoidable disadvantages are interconnected, and as you've heard, it has to do with culture and socioeconomic status and many other things that go beyond traditional health. They're cumulative, they're intergenerational, and they are, again, kind of reflecting on Dr. Mendoza's speech, they're associated with a lower capacity for full participation in society, and that's really important and going to be increasingly important in the future. There are great societal costs that arise from these inequalities, including threats to economic development, and I think that is going to be an important theme that will push us forward, democracy and the social health of the nation. So this isn't a nice to do or important to do, this is a gotta do for the success of our country. The other comment I'll make kind of before jumping into the talk is that because we have tried in the past and have only made modest, small, incremental advances, we should all conclude from that we've got to do some things differently. I think it was Einstein that said the definition of insanity is doing the same thing over and over again and hoping for a different result. We want a very different result, so that implies we have to do things differently. And what does that mean in terms of patient-oriented clinical and translational research and patient-oriented clinical and translational research be a vehicle to help us reduce these inequities. And I'll just touch on 3 things in my talk. We need to better understand what these inequities are, what these inequities mean in different subgroups of our society and across our society. And clinical and translational research can help bring that understanding with new and better data, new and more innovative analyses. Secondly, we're challenged in this country to devise better care delivery models, deliver medical care in different ways, much higher value. We need to get more for our money, if you will, with respect to health care. How can we build these models in such a way that they address equity? And clinical and translational research can help us not only devise these models, develop, test, validate these models, but also ensure that equity is a key part of the new models for healthcare that we're going to build in this country going forward, because without that, we're really not going to get where we need to be. And then the third thing I'll touch on with respect to clinical and translational research is this whole thing of implementation science that I'm sure you've all heard of. So we can produce data, we can come up with great solutions, but how do we implement these solutions into our communities and our society? And one of the key ways to do that is to promote health literacy in our society and among our people, because again, reflecting on Dr. Mendoza's speech, and we didn't actually talk beforehand or anything, if these interventions are not sustainable by the members of society and by the groups themselves, it's not going to work. And health literacy is just one example of how to ensure that sustainability, particularly in vulnerable populations. And then I'll just end by a couple of other factors that I think are necessary to reducing health equity, reducing health inequity, moving towards health equity, that are maybe doing things a bit differently than what we have in the past. And one is the importance of building social and political momentum through strategic collaborations. And then the last thing I'll comment on, which keep you awake through the whole thing, it's a little bit controversial, but it's the importance of communication, communicating and discussing things that might not be entirely comfortable when it comes to this particular domain. So what do I mean by better understanding and better describing inequities, and how can clinical and translational research help us there? I'll just share a couple of articles that I'm very fond of, really. I'm sorry, I'm just looking for the pointer. Oh. No, we don't have one. That's fine. I don't really need one. I don't really need one.
Dr. Mendoza.
Oh, that was yours. I got to get myself one of these. But this was a very interesting paper that described what they called the 8 Americas. It was basically an analysis of mortality across the United States, looking at all counties, so looking at data at a very much more granular level than we have in the past, and lots of information on population density and race-specific county information, income, violence, homicide rates, things like that. And they concluded really that there were 8 Americas in our country, and you can see there are different lines there. And these 8 groups were defined by these characteristics at the bottom. Location to some extent, but race, lower income, per capita income, so markers of socioeconomic status, and others. And these 8 Americas were really drastically different in their experiences. So depending on which of these 8 Americas you belong to, you're going to have a very different experience, even with respect to something as crude and as important as mortality. So disparities in mortality consist of millions or tens in these groups, which consist of tens of millions of Americas, were enormous. And if you look at, for example, the gap between the highest and lowest life expectancies for race-county combinations, it was more than 37 years. So, for example, mortality expectancy in the high-risk urban black male subgroup compared to Asian female subgroup, the difference was 21 years, and you're living in the same country. I mean, why should you have such an enormous health disparity in something like mortality? And these observed disparities in life expectancies couldn't be explained, and they did wonderful analyses to try and understand and explain these, but couldn't be explained by race alone, by income alone, or by basic healthcare access or utilization alone. And so there's something really fundamental going on here that we need to better understand, and this was one, I think, of the landmark papers that helped us see that. Because policies aimed at reducing these socioeconomic inequalities are, I would say, practically absent. We need to work on these health disparities, at least partly through the public health strategies that we've all been talking about and will continue to talk about at this meeting, by reducing risk factors for not only disease but injury, and innovative methods and tools that link population health and population disparities to these public health interventions are lacking. So what can clinical and translational research do? It can bring in the world of public research or public health and the worlds of public policies to help us understand these issues and link them together. The CDC is one of our few sources of data on health disparities across various populations in the U.S. As many of you know, I think all of you probably are rheumatologists, so I'll show you some arthritis examples, but some of these messages are true in many, many chronic diseases. And these are data based on 07-09 from the National Health Interview Survey at NIHS. Based on those data, about 50 million adults have self-reported and or doctor-diagnosed arthritis. 21 million have arthritis and arthritis attributable to activity limitation, and about 25% of adults 18 or over will have this by 2030. And an estimated 37% or 25 million adults will report arthritis attributable to activity limitations. So it's not only a highly prevalent condition, but it's something that interferes with activity and function and productivity of adults. And more than 1% of the GDP, the gross domestic product, across all states is attributable to this problem. So it's important. Well, what does that have to do with race and ethnicity? And when we look at the prevalence of arthritis by race and ethnicity, this is what you see. Non-Hispanic whites, pretty close to leading the pack with respect to prevalence. Non-Hispanic black lower, and Hispanic actually 11.1%, one of the lowest, and you can see the others. But what's interesting is when we look at things like work limitations. So for example, looking at Hispanics, the prevalence of arthritis is only 11.1%. When it comes to work limitation among working age adults with arthritis, it's 43%. So the work limitation attributable to arthritis is higher than what we see in non-Hispanic white, the very top line over here, in spite of the fact that the prevalence of the condition is actually quite a bit lower. So what does that mean, and what does that tell us? Likewise, activity limitation among adults with arthritis, you see the same thing. So activity limitation is much higher in these groups. Again, you can look at Hispanics. Sorry, my lines didn't line up perfectly here. Is quite a bit higher here among Hispanics than non-Hispanic whites. Again, in spite of the fact that this is a condition with half the prevalence in Hispanics. And I'm not showing you the data, but it's exactly the same thing when it comes to severe pain among adults. So whereas arthritis, and again, I picked this because it's the condition that's dearest to my heart, but it's the same for other chronic conditions. While it's a frequent problem, it's got a large impact across a lot of racial ethnic groups, but the disabling effects of the disease, arthritis attributable activity limitation, work limitation, severe pain, affect racial ethnic groups much more frequently and quite disproportionately compared to others. Likewise, when we look at the geography of the U.S., we, with respect to stroke in this case, for example, these are rates of stroke mortality in white males aged 70, and you can see there's this big southeast cluster, and the same. It started. These are data. These are older data, and you can see it's starting to break up a little bit, but we still have a predominant southeast cluster. And what is that telling us? Same thing with diabetes. We have where the poorest, least educated people in the country perhaps live. Same thing with diabetes. We have this southeast cluster, and the darker colors here represent percentage of adults with diagnosed diabetes. And this will look similar to the obesity prevalence as well. Another piece of data that helps us understand disparities and is an important application of clinical and translational research in helping us understand disparities is the whole new discipline, relatively new discipline of geographic variation. And so this is promoted by the folks in Dartmouth and the Dartmouth Atlas that demonstrates that there's variation now not in prevalence or an outcome of disease, but in the way we manage diseases. So there's variation in Medicare spending per capita in the U.S. by hospital referral region. So why is it that in some parts of the country we're spending $4,500 per Medicare in Medicare dollars per capita, whereas in some parts of the country we're actually spending $12,000 per capita. And in fact, generally, in the areas where we're spending more, our outcomes are quite a bit poorer. This is a unique research approach that I'm just going to share with you a little bit. I don't fully understand it, but as an epidemiologist, I find it really intriguing. And this is Dr. Mobley and colleagues, and it would be really interesting to map this out in Puerto Rico. She's not been able to do that here, but she's done it in a number of other states. And she's come to the conclusion that since there is considerable autonomy state by state and in Puerto Rico with respect to culture, politics, regulatory environment, it's more useful to examine states separately. And so she's promoted these geographic analysis study to translate these findings and then try to connect them to the public health interventions. So the public health interventions are state by state, and some of the health outcomes really need to be understood in a state by state fashion in order for these interventions to make sense. And again, what she's found in her studies is these clusters. So these are clusters of age-adjusted stroke hospitalizations for Medicare beneficiaries over 65. And the highest rate counties, again, are what I've showed you from the CDC data here, but it's a lot more granular than what we can get from the CDC. And then the low rate counties are in blue. And these are similar data, clusters of age-adjusted stroke hospitalization rates that show not only high and low, but persistently high, ones that are high and they just stay high despite intervention, persistently low, and then those that have transitioned from low to high and from high to low. And again, it provides us very interesting, much more granular information on what's happening county by county, and then to try to relate that to what are they doing with respect to public health in that county and how we can really make an impact on population. And what she's concluded is that the age-adjusted stroke hospitalization rate for medical beneficiaries are very significant. There are very significant differences. And it could be not just state by state, but within a state from county to county. So you could imagine if you did this kind of study in Puerto Rico, which counties would come out on top in terms of their health outcomes, and which counties would do not so well, and then look at what you're doing with respect to public health in those counties and what we can do differently. So even county by county differences were highly significant and were persistent using the spatial clustering technique. High rate counties, again, largely in the southeast areas with the least favorable socioeconomic and healthcare profiles, and counting transitioning into and out of high-risk clusters were also very interesting. They had socioeconomic healthcare and healthcare profiles that were more favorable to counties in the persistently high rate clusters. So if you're going from high to low or from low to high, they looked better than those in the high rate clusters, but not as favorable as those who were in the low rate and persisted in the low rate. Now, some of this is, you'd say, well, that's common sense. But the fact is, we've never had data at this granular level that talks about the geographical clustering of these characteristics and then again links them to public health. And it really does add a new dimension to understanding the role that social determinants and public health plays on health disparities. With respect to, in this case, the burden of stroke, but she's done the same analyses for a number of other important chronic diseases. So descriptive population data, like what I've shown you, focused at at-risk populations and really being able to subdivide those populations as much as we can is critical. Such data for most conditions is lacking. It's starting to come in now, but innovative methods such as these spatial translation of population methods really can provide us very unique insights, much more powerful than what we can get, with the National Health Interview Survey or some other things that are currently done. So that's just one example of how data and analyses and more innovative approaches through clinical and translational data can help us understand disparities at a much deeper level. So moving on to models of care, we're at a time in the U.S. where we must change the way we deliver care. It's not an option for us anymore, and it's important as we do that our clinical and translational research initiatives address health equity as we are transforming our models of healthcare. And why is improving value and changing the way we manage patients and the way we deliver care important? And this will resonate with what you've seen before. We all know that the world is aging, and this is just a picture of what we look like today. And the blue category is the percent of the population 60 years or older, and blue reflects more than 20, and of course by 2025, this is what we'll look for. That's why it's so important for these young people to be looking after this huge population of individuals 60 years or older. And so by 2025, and these are just some more of the data that will underscore this, the U.S. population, I love Florida, I have a home there actually, but will look more like the population of Florida looks today. There'll be as many walkers as there are strollers, and about 1 in 4 people will be older than 65. And if nothing changes, population disparities with respect to rural, racial, ethnic, sex will likely increase. And so this is a burning platform, I guess. Other reasons why we must do things differently in terms of changing the healthcare delivery models. Again, these are things that you've all seen, and I've seen it many, many times, but it bothers me every time I see it, frankly. And these are data from the OECD, and with life expectancy on the vertical axis here and healthcare spending per capita on the horizontal axis, and all the countries in the world are plotted on this. And generally, kind of the more money you spend, the better the life expectancy. And here we are, way over here. We're just such an outlier from the rest of the world. What is it that we're doing differently here? And it corresponds to about $3 trillion, about a fifth of the GDP on healthcare. And so we're spending a lot more, but really not getting what we should be getting in terms of life expectancy. So we're spending way more than everybody else, but really are about way down here with respect to life expectancy. And I would argue that some of that are the problems that you all are trying to address at this meeting, and that we're all trying to address with respect to health equity. And these are similar data, just looked at a little bit differently. Healthcare spending, again, per capita on the vertical axis and GDP on the horizontal axis. and here's the U.S., really quite an outlier. It's actually surprising how the other countries line up kind of nicely on the straight line, but we certainly don't. And if there's been a lot written about the fact that some of this increased health spending that we have in the U.S. is starting to go down, and that is true. If you look at this last little 5-year blip here in the gray, the rate of spending has gone down, but it still is far higher than it ought to be. And there is little doubt that what we need to do in this country is to increase the value of healthcare. And so when I talk about changing healthcare delivery, changing the way we deliver care, we generally talk about improving the numerator while decreasing, or at the very least holding, the denominator. So increasing quality and outcomes, lives saved, health gained, people satisfied, and really holding down costs. One other approach, and again, this is an example of clinical and translational research at work, clinical and translational research with teams that are very multidisciplinary. So when we bring health policy folks to the table, when we bring health economics folks to the table, we can look at these questions in ways that are different from just having the same kinds of experts at the table. And this is a very collaborative, multidisciplinary effort that was funded by the Rand Institution and also this Kaufman-Rand Institute for Entrepreneurship and Public Policy, a very diverse, very multidisciplinary translational group that looked at a lot of data and summarized it in this graph that they called the value chasm. I'll just go through it a little bit, really as an example of what you can do when you bring different kinds of expertise to the table to help address the healthcare challenges. And with costs on the vertical and benefits broadly defined, but really looking, well, benefits defined as the present value of aggregate expected quality adjusted life years. So taking kind of a broad bucket and translating it into quality adjusted life years, and then the present value of these aggregate expected healthcare costs. They came up with this curved line that separates feasible healthcare interventions on this side of the line. So everything on this side of the line is possible. Everything on this side of the line is just not feasible based on today's knowledge. So we can't spend a little bit of money and have, you know, a whole bunch of health benefits. I mean, some of these things just aren't possible. And then they called that line the value improvement possibility frontier, kind of a cool name. And basically this is where we are now. In other words, there's a lot of room for improvement, which they refer to as the value chasm, with respect to where we are today. So where we are today, and just utilizing today's science, today's knowledge, we could spend exactly the same amount of money and move all the way over here and get this much more health benefit on the benefit scale, or for the amount of benefit we're currently seeing in our society, we should be spending way down here rather than what we're spending up here. And so the focus of this particular analysis is to try and understand that value chasm and try and understand why is it that we're not getting value for our healthcare dollar in terms of outcomes, and what we can do differently to achieve that, to overcome that value chasm. And a part of that must be addressing health disparities. So with respect to new models of care, new models of care delivery, the importance of enhancing the quality and value of care, again, just to reiterate, our country spends more on health care than other developed nations, even adjusting for wealth. And we're just not getting value for the money spent. The healthcare spending continues to grow faster than the economy. The rate of growth has been a little bit lower, but it's still faster than the economy. Payment reform alone, which you hear a lot about in the media, is just not enough. We've got to do things differently. We've got to deliver care in a very different way. And there are a lot of innovative ideas for transforming our healthcare delivery system and reforming our healthcare delivery system. But a key part of that has to be addressing the inequities that we see in health and the healthcare disparities, because they are a major contributor to these large unexplained variations that we see in care. So in order to advance healthcare quality, to reach that high-value healthcare that we all are aspiring to, these new models of care must address health inequity. So the third example of how clinical and translational science, multidisciplinary teams are needed is the whole area of implementation science. So even when we produce these wonderful data, this new knowledge that can get us where we need to go, it's got to be disseminated, it's got to be implemented, particularly with respect to vulnerable populations. So I'll just touch on health literacy. This is too many words here, but there were such great words I had to put them all on there. But this is a book from the Institute of Medicine, one of their textbooks on this issue, entitled Towards Health Equity and Patient-Centeredness, Integrating Health Literacy, Disparities Reduction, and Quality Improvement. And they talk about how our country has experienced these vast demographic changes, particularly in this last generation, and emphasize the importance of thinking about the way healthcare is delivered and changing that in much more dramatic ways than we have in the past. With more diverse cultures and languages, our providers now must tailor their healthcare in ways that they haven't been used to doing, that they weren't trained to do, to ensure that the care is equitable and patient-centered. And quality improvement with a focus on reducing healthcare disparities and enhancing health literacy is vital. It's vital to assuring better health for the nation. So I think there is this general groundswell of understanding of the importance of not only improving, addressing health disparities, but the importance of health literacy on that path. This is a study. It's a little bit old. But I think the results are still relevant. Again, talking about health systems. We're all talking about how we're going to change our health systems. Well, these health systems are going to face major new challenges in this next millennium. We've got to strike a balance between quality of care and the optimal use of resources, and really cut back on those resources. And healthcare policymakers will be challenged in ways that they've never been challenged in the past. One of the things that this particular analysis concludes is the importance of partnerships. So it can't just be any institution. Even Stanford alone or Mayo Clinic alone isn't going to get there. We've really got to partner and work together. And it's for these reasons, because we need to work together and work together not only across institutions, which we're beginning to do, but together with our communities and the people who will be affected by these new care models. And for those reasons, health literacy just becomes even more important for improving self-management. So again, an arthritis example. This was a study published back in just a couple of years ago on health equity and health literacy in arthritis, and how improving health literacy can really move us at least one step towards health equity. So the WHO in 2008 and PCORI, which I'm not talking quite as much about as Clemente said, but I'd love to talk more about it if you're interested. They promote patient-centered care models, and so there are huge initiatives underway both globally under the auspices of WHO and in the U.S. under the auspices of PCORI to build these patient-centered care models where patients are truly equal partners in planning, managing their health. But they're doing that through research. And so PCORI, as an example, the Patient-Centered Outcomes Research Institute, requires that patients are involved in the studies that are submitted to that. It's required that patients are involved in meaningful ways in helping define the research question, helping define the approach to how that question is going to be answered, helping define how the results are going to be formulated and disseminated and implemented. And so patients being involved in the management of their health now extends to patients being involved as critical partners in clinical and translational research teams. So a critical member, perhaps the central member of that team is the patient. And the expectation is improved disease management, health outcomes, patient satisfaction, and so on. And there's been some question as to whether interventions to improve consumer skills are really appropriate. What can it really be done? Can it really be done in vulnerable populations? And this particular study that did an analysis in vulnerable populations in arthritis proposed that these populations have the most to gain and perhaps are the ones that we should focus on the most. And this analysis by Radar and colleagues investigated domains captured by a particular index in relation to vulnerable populations that experience health equity, and really concluded that particular focus on the domain of health literacy is an area that's fundamental to patients' involvement is going to be critical going forward, and is really a key domain to influencing effective consumer skills among disadvantaged and vulnerable groups. And so I kind of glossed over this quickly, but health literacy, if patients are truly going to be partners, not only in delivering their care, in self-management, but also in helping us craft better clinical and translational research projects that address questions that are really important to them, then health literacy becomes foundational to that kind of effort. So the last two things I'll comment on are a little bit farther afield from clinical and translational research. We all know that the U.S. is facing what some call a perfect healthcare storm. We've got the aging of the population. There's increased cost of care, rapidly increased complexity of care and of the medical science that is foundational to that care. I've shown you all kinds of stuff about variations in care, and at the same time, I haven't shown you these data, but there's been great analyses that demonstrate that there's a lot of waste in our healthcare system, and that some of that waste leads to harm, and certainly some of that waste leads to missed opportunities. So we're in the midst of this perfect storm, and to me, a critical step to enabling us to get to the solutions that we seek is building social and political momentum through these strategic collaborations. And I've just made a quick list here of some of the strategic collaborations and interactions that are going to be critical, even more critical in the future. WHO and PCORI I've mentioned in the past, and when you look at what the World Health Organization is promoting and what PCORI is promoting regarding patient-centered outcomes research as foundational to transforming our healthcare system and improving health, they're really pretty analogous. And so what can we do in terms of aligning with, at the very least, and perhaps interacting and collaborating with the efforts that are underway at PCORI and at the WHO. The Institute of Medicine is another important place where we can look at, they're constantly producing important data, important conclusions that are drawn from those data as to what needs to be done to transform our healthcare systems, to improve health, and to address disparities in equity. Academic institutions, like many of the ones represented here, strategic collaborations are popping up all the time and are going to be increasingly important because everything we do moving forward really must be centered around the patients. Patient organizations are becoming even more important than they have been in the past. What can we do again to collaborate with, interact with, and bring those patient organizations as key stakeholders to the table? And then other important healthcare stakeholders. Insurers are critical because in the this country, of course, they pay for care. And so what are their perspectives? How can we bring them to the table? Large employers that also pay for care for their employees can provide an important perspective. Industry, and I could have gone on and on. And, you know, of course, we're a wonderful example, I think, of at least two institutions that have a somewhat disparate, certainly disparate geographically, but a somewhat disparate missions even, that have made great strides with respect to their collaboration and others represented here as well. So my last couple of minutes, I'm just going to be a little bit provocative. And my last comment really is that none of this can happen without open, transparent communication around the notion of health disparities. Even when it comes to discussing uncomfortable topics that might underlie some of the disparities that we all see in our practices and in our institutions. And this is just a little cartoon about racism. And this is Bob over here, who says, you know, I don't know why we need to talk about this. I've never benefited from racism. And this cartoon goes back to Bob's great-grandparents and how Bob's great-grandparents got into the U.S. And there's this, I guess, politician who says, our immigration laws should make it easier for the right kind of people to immigrate. And then how Bob's grandparents became homeowners. Well, here's Bob's grandparents getting their first loan, and somebody saying, we're happy to approve your mortgage loan. And there's another couple back here that look a little different from Bob's grandparents who are getting denied their first loan. And it's just a cartoon, so not, you know, some data. How Bob's dad began his career, and here's somebody congratulating Bob, his boss, I guess. We like you, you seem like one of us, we're offering you a foot in the door, and somebody else is told the position is filled. And you can see it just kind of goes on, how Bob's parents became homeowners. We only show homes in this neighborhood to the right sort of people. How Bob got through his teens, and here's Bob getting, you know, I guess pulled over by a policeman who says, I'm going to let you off with a warning this time, but if I catch you with drugs again, and this poor young lady is under arrest. And so this is just, you know, a clip, something I found, you know, in my little search, to underscore the importance of open communication. There are some uncomfortable topics around the area of health disparities and reducing health disparities, and if we're really going to get there and going to do things differently in order to make greater progress in the coming 10 years, we can't be afraid to talk about all of the topics that surround the issue of health disparities. So that's my talk, and I'd be happy to take a few moments to answer questions. This is one of our lobbies at Mayo Clinic, and I'd love to see many more of you there. I've seen many of you there, but I'd love to see many more of you there. So thank you for your attention.
Thank you. Any questions? We have, because of time constraints, we really have time. We have 3 minutes, so we can avail ourselves. Any questions or comments? I have one.
Okay.
We've talked about, and training is something that we've done throughout this time that we really have wanted to impact and we have sustained. And you talked about high schools, and I think Fernando mentioned this. Early interventions are going to be critical. Tell us a little bit about how you're doing that intervention, how you're bringing in those high school students into Mayo Clinic, and how are you sustaining it? How are you funding it?
Well, we're just starting, and so I did want. It's exactly true. We're seeing exactly what you said, Dr. Mendoza, that it's important to go outside of our institutions and to reach not only to the undergraduate population, undergraduate students, and with respect to that group, we're collaborating with colleges around the region. And trying to invite some of those undergraduates to Mayo to give them a sense for, you know, what a career in health and in medicine could look like, and also working with some of these undergraduate colleges to create post-bac programs, particularly targeted towards disadvantaged students of all kinds. So students who may not not have had the same kind of support through high school and their early years, the same kind of family support, who might be interested in pursuing a career in medicine, but really aren't as well prepared as their peers because they haven't had the opportunities that their peers have had. So we're creating some post-bac programs to take some of those students and give them an extra 2 to 3 years to really prepare them to then compete to be medical students at Mayo or at Stanford or anywhere else. But if you just, without that, they really wouldn't be competitive. They might have the capabilities, but they wouldn't be competitive. So that's one thing we're doing with respect to the undergraduate student is building post-bac programs with in collaboration with some of the colleges in our area to prepare those, better prepare those students. And we're just starting to work with high schools. We're going into the local high schools and really trying to just drum up interest and provide opportunities for those students to have 2 or 3 week experiences with us at Mayo, and again, experiences with the local colleges around us. Funding, as you alluded to, is a challenge. There are a few foundations that are very interested in education, and we're looking to those foundations to help fund some of these collaborative opportunities, but the key is collaborative. So we, Mayo Clinic, can't do that by ourselves. We have to do it in collaboration with the communities, in collaboration with community colleges, in collaboration with the schools. You may have also heard about the Inside Out program that we have at Mayo that's gotten a lot of play recently. We have even one picture with Obama at one point, where rather than focusing on the students, which most of our programs do, this focuses on the high school science teachers, science and math teachers, and we're actually bringing them in to Mayo for special educational experiences that then they can take back and take to their students. So we couldn't agree with you more about the importance of reaching into the undergraduate student population and the high schools, and perhaps even earlier. We haven't gotten earlier yet. And I agree, Clemente, funding is a challenge, but we've been able to identify some foundations that could help us with that, and I'd be happy to share those with you because they're very much interested in expanding their scope.
Quick question. In terms of the way we provide the healthcare here in the United States, and the amount of dollars we spend, we say we don't get the same amount of benefits. Have you ever looked at the same aspects in other multinational ethnic countries like Canada, England, France, and compare the Puerto Rico system with the Cuban system? That's the problem.
Compare them with what?
With the homogeneous population like in Puerto Rico, and compare with the Cuban population in Cuba, how the healthcare system provided.
Yeah, well, I mean, some of the data with respect to Canada and some of the other countries you can see there, and so they tend to have better outcomes with lesser investment. I would love to look at it, what it would look like if you just looked at Puerto Rico or compared to the Cuban system. I don't have data on that, but it's a great question.
It's a great talk, and I guess my question, and this is probably not going to be a very short answer, so maybe just to think about, is I recently reviewed a paper for a journal where the authors measured by national surveys 256 measures of disparity. And my commentary was, well, and they said some went up, some went down, some stayed the same. So it struck me that the issue really for us is determine what are the key aspects that we would say, these are the key aspects, they've changed, so we've gotten better. Do you have a sense for that? And that's probably a big answer.
Yeah, no, well, it's probably, I don't have the answer to that, but I couldn't agree with you more that we've got to standardize the question. So we haven't even, as you're pointing out, we haven't even agreed on the question exactly. And if we can, that's the first step. And this is again a place where clinical and translational researchers need to step up and say, okay, we have looked at the 356 definitions of disparity, and we as a community are going to say that these 12 are going to be the most important. And we've defined them, and here are the reliability data and the validity data and all of the testing, and you know, do the political piece that I've talked about and get the IOM to say, yes, those are the best 12. And so that is really hard work that needs to be done, because sometimes, and this is maybe too negative, but sometimes when I see the 256 and someone up and someone down, I think, well, you weren't really interested in answering the question, were you? Because that first step has to happen. And I would say the clinical and translational research community needs to step up and define what we mean by disparities, do the hard work, validate, get all the buy-in and so on, and then get the big political bodies to put their stamp on it, and that will move forward the field very dramatically, but we're not there yet.
Thank you so much.
Now we're going to our morning last presentation. We're going to run until 12:45. We're going to have lunch until 1:15. And we will appreciate if you fill in the evaluation form before or during the lunch time. I'm going to call Dr. Elsa Orellana, that she's going to moderate this session.
Thank you. For me, it's an honor to present Dr. Gail Mountain. She's an outstanding occupational therapist and researcher that came all along from the United Kingdom. And we are pleased to have her here. But best of all, she has been instrumental in my professional development as a mentor and friend since 2009. So specifically, Dr. Gail Mountain is a professor of health services research within the Rehabilitation and Assisted Technologies Group. She also has an honorary share in occupational therapy research at Sheffield Hallam University and research associate in the Lab for Living Design and Health Collaboration. He's the director of the SMART Consortium and principal director of the KT Equal Consortium, which is engaged in transfer of knowledge out of research to benefit older and disabled people. She also leads randomized controlled trials, which are looking at the effectiveness of specific interventions which aim to promote well-being in later life. So welcome, Dr. Gail Mountain. Thanks for being here.
Thank you. It's an honour to be here, though I'm constantly surprised that I am here. This is my second trip to Puerto Rico. I don't think Puerto Rico, I'm not saying that correctly. Puerto Rico, I can't say it. Okay, so what's an English woman doing here? And what's England got to do with it anyway? What do you think about when you think about United Kingdom, England? We have to be careful, England, where I come from. Okay. Do you think about the weather? Well, you certainly do. Rain, you have no idea. Okay. Do you think about the royal family? We seem to be pretty preoccupied with that most of the time, what they're doing, not doing, who they're with, not with, etc., etc. Do you think about the health service? Yes. Because it's interesting to hear things I've heard this morning. The terminology that I've heard are the same. Self-management, health inequalities, social determinants of health, implementation science, translational research, it's the same. And even though the graphs that we've just seen show us not doing too badly, I suppose, in terms of outcomes per kind of delivery of health care, in our country, scandal after scandal, week after week, about care, particularly for older people. It's a big issue. So we're not doing great, really. I want to share with you some of the research that I'm involved in. However, actually, does anybody want to stand up first and stretch? Nobody wants to. Do not do that here. Please do if you do it, because you know the armchair's a killer. We've all got that information now. Do stretch. Okay. Okay, because it's. I once said that in Norway, and everybody walked out. Because in Norway that meant that people actually went out. And I'm aware how easily things are lost in translation. Actually, I think there's more difference in words between the UK and the US than there is between the UK and other European countries in terms of our understandings. So some things I might have misinterpreted. I struggled with translational, for instance, and what you exactly meant by that term. So let's go forward, and if I say anything that anybody doesn't understand, because it's not the words I say, I think it's the way I use them sometimes, please can you indicate? Because I think we do lose things in translation when we go across different countries. Okay, so it's interesting. I came to Puerto Rico 3 years ago now, and what I picked up then, and this may be wrong, you can shout me down, was that it was still a fairly medical model of research that we were working in here. Now you may say that's wrong, and it's interesting that in my whole portfolio, and I work with technology research, I work with prototypes, I work with implementation of technology, I also work with complex interventions and trials, that I chose to focus on randomised controlled trials, because I felt that would suit you better. Now, I'll leave that with you. Why did I think that? And is that correct, or am I completely wrong about that? So, given that I thought, well, I'm doing trials now, this is what will go down fairly well with the audience. I had a bit of a choice, and I had some interaction with the people organising this event about what I should focus on. So I could have talked about a pilot trial on telehealth that we've conducted. I could have talked about telephone befriending, which is a trial. Instead, we chose the latter two options. Particularly lifestyle matters because Elsa and I have been working on, and this is a particular topic that we've been focused on over these last 3 years and more. Okay. But we can return, and I will explain what catch means at the end. Have anybody come across this? UK Medical Research Council Complex Interventions Framework. I do a lot of reviewing for research as well as doing research, as I'm sure everybody does here. And how many times, every time now, everybody quotes this. It's getting a bit boring. However, it is quite useful, because what it's saying is you need to develop the intervention first. A complex intervention needs to be specified. Then we need to look at the feasibility of delivering that in practice, translational. And that might go back again to the development phase. After that, so we're following the trials methodology route, then we think about an exploratory, a pilot trial. Then we may or may not go to full evaluation and then implementation, but each informs the other. It is a useful framework, but I think we're kind of overusing it slightly. Okay, so I'm going to talk about this one quickly, Lifestyle Matters. Funded by the UK Medical Research Council until next year. It will be equivalent to about $2 million US, I think. Okay, so it's a whole programme of research. It's a randomised control trial and 2 feasibility studies. It's amazing, really, to me that an occupational therapist managed to get this money, because in the past, to get any money out of the Medical Research Council UK, you couldn't have done it. Things have changed quite a lot, and I've benefited from that. And you can see the whole range of people involved, and it is very interdisciplinary. So it's occupational therapists, health economists, trial managers, social scientists, psychologists, health economists, and so on. Okay. I'm not going to dwell on this, you know this, don't you? Healthy ageing. The counter to the problems of the ageing population is to compress morbidity at the end of the lifespan, to keep people going for as long as possible so that period of morbidity is reduced. And to equality of life as well. We're living till we're dead, whatever is wrong with us. We've got to promote our quality of life. And more recently, and there will be a document coming out of the WHO fairly soon to look at some of the benefits of the ageing population as well as a kind of this catastrophe scenario, which I got very bored with as well in the UK. The graphs, we're all kind of aging. We're all part of that. So I want to kind of contribute for as long as possible. So this is an approach to healthy ageing, developed in partnership with older people and for older people. And the interesting thing is, there's some of our older people in an English pub. Yeah, anybody been to an English pub? So yeah, enjoying a meal there. It's a preventive health approach, underpinned by the belief that what we do every day is central to our health and well-being, participation. And also, importantly, the final point, you can only get positive results out of this if it's embedded into a person's day-to-day life. So in the past, as an occupational therapist, say working in day settings for older people in the UK, which I did, then people used to say, well, I do this when I come to the day centre. Well, that's kind of a bit of a waste of time, isn't it, really? It's got to be translated into people's daily lives, otherwise it's not going to work. I should actually stay, I don't know whether I'm looking to see, this intervention is based on a US intervention called Lifestyle Redesign. I don't know whether anybody's heard of that at all. Developed by occupational therapy researchers at the University of Southern California, and we took forward the intervention and customised it into a UK context, and since then it's gone further than that. So these are the things, okay? Intervention delivery, and this is our UK version, our manualised intervention. It's about specifying the intervention, which we have done. Weekly meetings for this trial, 16, monthly one-to-one sessions as well, so people meet together in a group, but they also have a monthly session with one of the facilitators. US intervention, qualified occupational therapists, not affordable in the UK. Interesting what you just said about the costs of healthcare. We have to admit that. We can't do it. So we're looking at lesser qualified individuals and training them. Church halls, that's a church hall there, that kind of venue where people can get to it locally, meet together, get there by their own transportation, and activities identified by the people, not by the facilitators. And the important thing is positioning the older person as the expert. So people come, they've got life experience, they've got knowledge, they've got skills. Bring it, share it, help each other. Okay. Oh yeah, here we are. I have a whole list of references for you, so you can see that the US was the inspiration for this intervention, and it still goes on in Los Angeles in particular. Okay, so this is some of the detail, and I'm not going to dwell on this because we haven't got time and it's not too long to lunch. So to our parallel group, including evaluation of clinical and cost effectiveness based on quality of life being the primary outcome, and a process evaluation to look at qualitatively about what is it about this intervention that may or may not work. And there's a little bit of an issue here. The funders wanted a 2-year follow-up. So that's why we're going on to 2015 and we just start follow-up data in the summer. That's rather a long time, I feel, in the ageing trajectory, but we'll see. But that's what they wanted. So to get that kind of money, you have to say, yes, we'll do that. But the primary outcome is 6 months following cessation of attendance at the group. Okay, so just to tell you how we got on a little bit. We reached target in over 2 sites in the UK where I work, Sheffield, UK, which is a northern city, and North Wales, which is a very rural environment. Okay, so we had the additional tangle of couples, but we sorted that out statistically. Okay. Recruitment strategies. How do you reach older people in need? It's a problem. People aren't hard to reach for nothing, are they? The most successful method was GP mail out. Arguably, that's not the best way. In our feasibility study that we did before the main trial, which was 2004-5, we recruited through community activists, and that was better. But to do this at scale, when we move from a small feasibility study to doing things at scale, then it becomes a different ball game altogether. Okay. We tried very hard to get recruits through referrers like district nurses, community occupational therapists, community physiotherapists. We were not successful with that, and that's interesting. People seem to be in a groove of doing the things the way they always did it, and couldn't remember about us, I felt. We put a lot of effort into that, and it wasn't successful. This is the attendance at the groups. It was complicated. Any intervention which involves group delivery is complicated because you've got to get people together, you've got to agree that everybody can meet together at the same time in the week. So that you get quite a lot of attrition happening because people say, oh, I've got the hairdresser that day. Older people in particular value, even if there's just one thing in the week, because it clashes with the time that's being suggested, then it's not going to happen because that one thing is valued. So it was complicated. We talked about the therapeutic dose there for being 8 weeks. We didn't get such good attendance as we did in the feasibility study, but again, at scale, things dilute, I think. Yeah, the lowest number in the group was 9, the largest number was 16. Factors, here it says, enough people to start a group. We worked in communities so people could access easily. Enough participants getting willing to meet same day, same time. Recruitment saturation, have you reached everybody that's interested in that area? How long you've got people waiting, people forget, lose interest, and delivering it within the project plan and staff contracts. So, yeah. Not all participants attended each session, okay? And we did have some withdrawal during the programme. The one-to-one sessions. Now, this is an important aspect of this particular programme, and indeed the originator of the programme has emphasised this more recently in their second study in Los Angeles. That the one-to-one sessions is where people set their individual goals with the facilitator. So, for example, it may be, I want to learn about public transport because my husband used to drive and now he's died and I've got to get around on my own. It may be, I want to go out shopping but my family are telling me I can't, I still want to do that. How can I manage that dilemma? For example, so there's loads and loads of different vignettes you can imagine. So we were not successful, particularly at the one-to-ones, and that bothers me with the trial kind of outcomes, really, but we will see. And, oh yes, another thing is that our trials unit in Sheffield is very, very stringent, and so it's clear that we cannot analyse any of this data until all the 2-year follow-up has been collected. The reason being that we would prejudice our results if we analyse 6 months later. So we're waiting. All we can draw on now is the results of the process evaluation and fidelity checks. Okay, so to deliver the programme, all the facilitators received the same training, and that was also checked for fidelity. And then it was a number of sessions were videoed, and the fidelity of the facilitators to the programme was then checked with a checklist that we developed. So yeah, just going on to it, yeah. All sorts of different ways to try and see if they were able to replicate the programme in the way that it has been intended. It's quite different to a normal sort of delivery. People find it difficult because empowering the older people means, for example, that we can't say you can't do something because that's risky. It's up to that individual to decide whether they're going to do that or not. That can be a dilemma. People trained in a professional discipline like me, we were taught that we knew best and people should do what we we said. Now this is quite different as part of the group and the individual deciding for themselves. So it's about adherence, whether people were able to do that, and also whether people attended. We also interviewed everyone that delivered the programme, and also the facilitators, I should have said, did have supervision from qualified occupational therapists as well. So, and for the process evaluation, again, in-depth qualitative interviews with a sample of people who attended the programme. So, as I said before, we can't give you any results because we're not allowed to analyse them. And we're in the middle of analysing the qualitative findings and fidelity. However, I can tell you a few things. We find that the facilitators did not change their attitudes and understanding, but they did develop and improve their skills over time. Okay. So their fundamental understandings didn't change. We'll see how the results of the main trial kind of echo with that. They did enable people to contribute and encourage the group to make decisions rather than instructing and leading. However, group dynamics themselves are very important. One or two groups did have over-dominant individuals in them, and you can imagine some of the ramifications of that. And it was very incumbent on the skills of the facilitators to be able to manage that. It was about sharing and developing coping strategies. They did have opportunities to try out new things, and community facilities, they developed changes to their routines and behaviour. However, unlike the original feasibility study that we conducted, less evidence of people taking control at the end of the group. In the feasibility study which we conducted, and there were two groups there, they still run today. And we're talking 9 years later here. But we'll see. I don't know about this. And also the delivery went down to 4 months, whereas in the feasibility study we were talking 8 months. But again, it's about affordability. In the UK context, this is it really. 4 months is the maximum. So what are the learning points for implementation? Because this is what it's about. How can we translate out, even now, what we found from this trial? There's a methodology of contribution. Complex group-based interventions are so problematic, so challenging to specify and to evaluate in this way. I'm on a committee in the UK called Health Technology Assessment, which is all sorts of different interventions, evaluating particularly through randomised controlled trials. And more in the UK, they are commissioning this kind of research. I've thought about it quite a bit. It's in response to the chronic conditions issue, isn't it? But it took me a while to work out what was happening. Initially, when I joined this committee, it was quite a lot of drug kind of pharmacological research. It's really changed, and it's about that response. But it's really, really quite challenging. How to reach those most in need? People aren't hard to reach for nothing. How do we get to those people? However, somebody may be in need and it doesn't appear that they are. Somebody's just retired, somebody's just been bereaved, a younger person. It's not always the archetypal kind of frail older people thing that we're talking about here. The most important thing is service readiness. In the UK, there is no prevention services at the moment, apart from those run through charitable organisations, third sector organisations. Certainly within the health and social care system, this kind of thing does not exist. So even though it's recommended by policy, where are we going to deliver it in the future? I don't know. There's no infrastructure for preventive services, or responsive once people have begun to slide. And what are the training and supervision requirements required for best delivery? And there's a whole list of references for those of you who are interested. Okay. I'm going to now talk about another one. Is this okay? Are you still with me? Yeah? Yeah. I know I've taught in a lot of English colloquialism. I've become so aware of that the more I've travelled. So this is another complex evaluation through randomised controlled trial. I'm particularly concerned about people with dementia. I always have been, because when I was a clinician, this was one of the groups I worked with. And isn't it odd? Well, in the UK, I constantly think, isn't it odd how we suddenly realise there's a lot of dementia around? Why suddenly are we all concerned about this when it's been apparent for many years? Is it the same here? Suddenly, well, we've got to manage these people with dementia. People have always had dementia. I mean, I know it's to do with increasing aging population, but it's been quite strange because until very recent in the UK, the diagnosis, once a person had got the diagnosis, and not many people did, then really it was over to the carer to deal with that person, and the emphasis of services was on the care. Nothing for the person with the condition. Is that the case here? You can forget it really, unless the family are going to care. This study, this shows you where I actually live. There is life beyond London in the UK. So this study is based in London, that's where the most sites are. Sheffield, where I work, which is a bit further up the country, and also an even lesser known place called Hull, which is on the coast just there. 3 sites. But within London there are a lot of sub-sites. Okay. Now what we're doing here is a little bit the same to what I've just described, in that we translated an intervention, this time from the Netherlands, which was reported in the British Medical Journal, 2006. It was a PhD study actually by Maud Graff, and it was concerned with delivery of community occupational therapy to people with dementia in their own homes and their carers. And it reportedly had great benefits, so everybody was quite excited about this. So we decided that we would try and see if this again replicated within the UK. If we can get these positive results. Okay. And again, it echoes policy in the UK around dementia. So we've got the National Dementia Strategy, which really was a watershed for dementia services. So we're talking about support and treatment for people with dementia and their family carers. Okay. So again, partnership and collaboration. All these interventions cannot be done without partnership with services. They can't be done without other people delivering. They can't be done without the collaboration of the older people and, in this case, their family carers. 2 clients here, people with dementia and their carer, in the home or in their local community, and based on what people want to do and their beliefs, habits, roles, what they want to go forward with. This is just some of the inclusion criteria. And we've kind of decided he's the face of Valid, this man. I'm not sure who he is, but he keeps popping up and everything. This is one of our recruitment brochures. Okay. It's quite, but the occupational therapists here will understand this, I hope. Maybe it's about assessing these, goal setting with the person, what do they want to do, and then identifying the intervention going forward. We've had a big development phase, and we're still kind of at the end of that, really. The translation of this intervention from Dutch into English. But more than that, also the customisation of the intervention from what meets the needs of people in the Netherlands to what meets the needs of people in the UK. Anybody been to the Netherlands at all here? Okay, well, quite a different race to the people in England, I feel. And it's reflected in this. It really is reflected in this. And I would say that if Maud was here. We're different. The healthcare delivery is completely different there. It's insurance-based again, a bit like the US. An occupational therapist in particular could only have 8 weeks worth of intervention with people in their own homes in the Netherlands. So this intervention is based around that, really. Whereas in the UK we don't have those sorts of constraints. And in the UK we have been working in the community with people for far longer than they have. However, in other ways, no disrespect to people in the Netherlands, it's just different. And it's appreciating those differences and also the reactions of older people. It's different. Our older people in the UK will say, yes, I'm doing that, and they're thinking all the time, no, I'm not. It's kind of like overt compliance and covert, no, I'm not. I think in the Netherlands, people are more likely to say yes or no, for example. Okay. Progress so far. This intervention means that we have to train loads of occupational therapists in this intervention. And Maud has been coming over from the Netherlands to train people. We need to rethink that. She can't keep coming over to the Netherlands to keep training people. This is for the first development phase, and also looking at giving occupational therapists the practice in the intervention. We've also had focus groups of people with dementia, their carers and occupational therapists, separate groups, to look at what they think to this. And there's also been a national survey. Okay. Very initial findings. This is from the focus groups. So there's people with dementia and their family carers said, yeah, we think this might work, but the limitation on sessions was something that was questioned, for example. Okay. Occupational therapists, they think it's beneficial. They found the adherence to the research procedures, again, problematic. So I don't know whether anybody else is involved in research which requires clinician data collection, but you start hitting challenges the minute you start doing that, and we have here. Yeah, and they feel that peer support helps them with that. Okay. So, but I have to say, and this is well, I'm being recorded, it's not really off the record, is it? The most concerning thing about this particular programme is the challenges the occupational therapists, the people in my professional group, have had goal setting, which I find very worrying, because I felt that was at the core of our professional understanding, and they seem to find this inordinately difficult. And then thinking about that more, it's something about the way that care delivery has evolved in the UK, and there's a lot of, for older people, quick fixes. You know, quick assessment, and what's the problem? Oh, you need a mobility aid. We'll give you that. And yet, we know that people get more complex as they get older. So is a quick fix scenario the best way forward? Almost seems like that we're rendered almost unable in some instances to respond in the way that I thought we'd been trained. I don't know whether I'll need that editing out a little bit, maybe. Okay, so a lot of references there. Okay, so implementation through research, what I've described is two examples of randomised controlled trial research of complex interventions. And through the actual process of doing the research itself, we encounter all the implementation challenges and the knowledge that we need to go forward. Okay. Now, just before I finish, that's only a bit of what I do. I'm a member of this centre, which is the new Centre for Assistive Technology and Connected Healthcare at University of Sheffield, and this is the other bit of my work. So, say the middle image there, in particular, is research that I've been leading for more than 10 years, and this is self-management technology for people with long-term conditions. So we're very embedded again in self-managed, but using technology. And this centre is very cross-disciplinary, so we're talking about involvement with engineers, computer scientists, architects, social scientists, psychologists, mechanical engineers, electrical engineers, you name it, we're engaged in that. And we've also got a home lab space so that we can mock living situations. So I don't really just think I'm doing trials, and it's interesting, and I go back to why did I think that was a way forward for you today. I don't know. Perhaps I'll leave you with that thought, or we can have some discussion over lunch. Okay. Thank you very much.
Thank you very much, Dr. Gill. There is time for 2 questions, so feel free to. Okay, 2 questions.
One of the challenges in adapting open strategies and aging and the aging population is so important to us also is the heterogeneity of the population and the cultural challenges
Yes.
appropriate and bridging.
Yes.
Do you have those challenges?
We absolutely do. I don't. It's hard for me to know how much of UK news gets to you, apart from the weather and the royal family. But there's a lot of debate at the moment about controlling immigration. We are highly multicultural, particularly in the cities. Less so. I mean, obviously, going to rural areas of the country, that's not the case. But in the city I live in, then we have a big Somali population, we have a big Chinese population, we have Asian population. So yes, it is a challenge. One thing I've learned from, say, trial research is that we know these challenges exist, and maybe it's an issue for discussion, what was said earlier about Spanish speaking, but to make it too difficult in the first instance, if we took into account every ethnic group that we could work with, we'd make it so difficult that we wouldn't get any we wouldn't get any outcomes, any results at all that meant anything. But we are aware, and in particular US collaborators, which we do work with, they work very much with the Chinese population, say in Los Angeles as well. I'm interested in doing that, but we have to take one step at a time, I feel. But we are, yeah, very multicultural.
Yes, so I had a question regarding the ballot study. I know you were talking about building the capacity. I'm going to be talking a little bit about that this afternoon, about capacity building. And one of the things that came to mind is a train-the-trainer model. Have you considered the possibility of taking the 33 occupational therapists that you train, selecting maybe one or two of them to be trained by your colleague in the Netherlands so that they can continue the process?
I absolutely agree that we think that having a champion may pull people on, may improve fidelity to the intervention, because at the moment, those trained then were involved in videoing some of their interactions with people as practice, and we found variable fidelity to the intervention as well. And more than that, people just saying, well, we can't goal set with these people, which is worrying. So yes, we do have to find new ways, and that's one model that certainly I hope that we will take forward. The challenge there has been a buyout of those champions within each setting. How we're going to pay for that, and that's another thing, isn't it?
It's always money.
It always comes down to money. Always. Yes.
Okay, well, thank you.
Can I just, I'd like to present Dr. Esther Pay with something small from Sheffield, a bit of Sheffield steel. I live in the city I live in is Holmesmith Steel, so I'm really, meeting her again, I was inspired once more by her energy, enthusiasm, and the fact that she remembers me